All right, so what I want to talk to you about is teaching the evidence-based physical diagnosis at the bedside. And there are six aspects of the curriculum that I'd like to cover today. And as it turns out, only the first four really are evidence-based, but I couldn't resist putting the last two on there because when I think about the things that maybe I share with learners at the bedside, these are probably the six different sorts of subjects that you could touch on. The first is going to be likelihood ratios and their use in clinical reasoning. The second is the importance of stop rules. So those are combinations of bedside findings that actually argue against the diagnosis so much the workup should stop. And our learners should understand those. Using bedside findings to predict prognosis. The very important point that signs that have been proven to be accurate sometimes are absent, and that's a limitation of our bedside exam. And then two that maybe aren't quite as evidence-based, but certainly valuable, the value of empiric observation and then the value of stories. So let's go through each of these, and I'm going to touch on likelihood ratios first. There's probably no better way than to lose an audience than to talk about sensitivity, specificity, math right before lunch. This slide is only here just to point out the traditional measure of diagnostic accuracy is sensitivity and specificity. And what I have here in the first column are some of the traditional findings of ascites. So patients come into you with increase in abdominal girth. You're kind of wondering, do they have ascites? And we do these bedside findings. And the only reason I put this slide here is just to make the point. It is very difficult to make any sense of these numbers. There's really no lesson that I get from looking at these numbers. A much better way to measure diagnostic accuracy and to convey it to your learners is using something called a likelihood ratio. And I'm going to define it for you, and then we're going to go through some examples. But a likelihood ratio, you don't even need to recall this definition to be able to use them. They are very simple to use. But for those who are interested, a likelihood ratio is simply a ratio of the probability of any particular finding X, showing up in people with the diagnosis you're trying to make, divided by, in the denominator, the probability of that identical finding showing up in all the competing mimics of the same disorder. So let's take a look. You're interested, how accurate is really the fluid wave in detecting ascites? And so you're going to do a study, and that's how these likelihood ratios are actually derived. It's a clinical study. Everyone's coming to you with the clinical suspicion of ascites. 100 people, they have an increasing abdominal girth. And all of them are tested for the fluid wave. Then independently, they go behind a curtain, and someone will do the diagnostic standard ultrasonography. And let's say some of the folks turn out to indeed have ascites, and the others have competing mimics, fat, gas, other reasons that their belly size is increasing. And let's say in this study, 50% of those with ascites have the fluid wave, but 10% of those with the competing mimicking disorders also have the fluid wave. And so then the likelihood ratio of the fluid wave in detecting ascites is the probability of it being an ascites, 50%, divided by the probability of the same finding showing up in people without disease, the competing mimics, 10%. The fluid wave is 5 times more likely to show up in people with disease as people with ascites as people without ascites. Okay, that's it for math. The beauty of likelihood ratios is you don't need to remember any of that. They are very simple to apply at the bedside because really for every physical finding and every diagnosis, there's a unique number, a unique likelihood ratio that connects those two. And that number describes to you whether this finding increases probability and how much, does it decrease probability and how much, or it's useless to you. And these values of these likelihood ratios range from 0 on the left to infinity on the right. And when you see these numbers, put them in 3 categories. Likelihood ratios greater than 1 describe findings that are more often seen in the diagnosis you're trying to make than the competing mimics. Therefore, if your patient has that finding, it increases probability, and the bigger the number, the greater the increment in probability. They're nothing more than diagnostic weights. Those likelihood ratios less than 1 describe findings that the denominator is bigger. So these are findings that are more often seen in the competing mimicking disorders than the disorder you're trying to diagnose. And therefore, if your patient has that finding, it decreases probability, and the closer the likelihood ratio is to 0, the greater the decrement in probability. And then those findings whose likelihood ratios hover around 1 are just unhelpful to you because they're seen just as often in the disorder you're trying to make as the competing mimics. How much does probability really change? These are ballpark figures. Nothing at the bedside is this precise, of course, so it just gives you a sense of what these numbers mean. And an easy way to remember how much probability really shifts with these numbers is to remember 3 likelihood ratios, 2, 5, and their product, 10. And then the first 3 multiples of 15, 15, 30, 45. So a finding whose likelihood ratio is 2 increases probability 15%. One whose likelihood ratio is 5 increases at 30%. One that's 10 increases at 45%. Ballpark figures. This totally suffices for bedside reasoning. What about those likelihood ratios less than 1? All you do is invert 2, 5, and 10. The inverse of 2 is 1/2, 0.5. So 2 increases at 15%, 0.5 decreases at 15%. And just like 5 increases at 30%, the inverse of 5, 0.2 decreases at 30%, 10 increases at 45, and 0.1 decreases at 45. So these are just ballpark figures. And this then is that same table of what the likelihood ratios are for these classic physical findings in detecting ascites. Now, where does this come from? This is a summary of 3 studies, 200 patients, all of them presenting to the clinician with abdominal distension. And the clinician's suspicion was enough that this could be ascites that they went ahead and did the ultrasound. And what we got here is 2 columns of numbers. There's one for likelihood ratio if finding is present, and then the other is for the likelihood ratio, the far right column, for when the finding is absent. And if you ever read this literature, that first column, likelihood ratio finding is present, is called positive likelihood ratio. In that second column, likelihood ratio findings absent is the negative likelihood ratio. This is very confusing. Those adjectives, positive and negative in front of likelihood ratio, refer to presence or absence of the finding. They don't refer to the value of the number. So you may have a positive likelihood ratio that's 0.1, a particular finding that really decreases probability of disease. So that's a little bit confusing. Anyway, likelihood ratios are simple because this table, which findings increase probability the most? You just look for the biggest numbers. And it happens to be, there on the bottom, the presence of the fluid wave, a likelihood ratio of 5 increases probability 30%. And then farther up in the second row, the presence of edema. Interestingly, no matter what the cause of ascites, the presence of edema, most of them do have edema, so the presence of edema increases probability some 25%, the likelihood ratio 3.8. On the other hand, which findings decrease probability of ascites the most? You just go look at this table. Where are the smallest numbers, the values closest to 0? And as it turns out to be in the far right there, in the second row, the absence of edema turns out to be the most compelling argument that your patient with abdominal distension does not have ascites. They have fat or gas or obstruction or something else going on. And then the 0.3 belongs to the absence of flank dullness. That's a double negative. That means you percuss the flank and you elicit tympany. So the absence of flank dullness is the same as saying you percuss the flank, and flank tympany will decrease probability some 25%. Now, this is our ruler, and I don't know if you can see. You can't. I've colored this ruler. What I pay attention to at the bedside is likelihood ratios whose value is 3 or greater or 0.3 or less, because those findings increase or decrease probability 20-25% or more. Those are the things I'm going to focus on when I teach at the bedside for these particular questions. So this is what the evidence-based exam or the physical exam, when it's been tested, looks like for ascites. And no one is whipping out their calculators and calculating what the precise post-test probability is with these numbers. The way I would teach evidence-based physical exam is I would look at this entire slide and I would trim it down to this. When I'm at the bedside, the question comes up, does Mr. Smith have ascites? The only two findings that I'm going to let change my thoughts, increasing probability of ascites, are the presence of the fluid wave, the presence of edema. And the only two findings I'm going to let decrease probability of ascites are the absence of edema and the presence of flank tympani. And I don't talk or teach about anything else. That's really the evidence-based approach. It's not what really was that likelihood ratio, what is the precise post-test probability. It's just streamlining the exam to those findings that have been proven to be accurate when compared to diagnostic standards. Here's another example. You're at the bedside of a patient with chronic liver disease, and they have dyspnea. You're wondering, do they have the Hepatopulmonary Syndrome? And this is a summary of 6 studies looking at the bedside exam compared to our diagnostic standard here would be they have cirrhosis and a contrast echogram showing that they indeed have right to left shunting. This is what the whole exam looks like. The evidence-based exam looks like this. So the lesson for your learners, you're at the bedside of Mr. White. He has chronic liver disease. He's coming in with shortness of breath. The question comes up, could this be hepatopulmonary syndrome? And the lesson is the only two findings that increase probability of that diagnosis are Abraham's clubbing and the presence of cyanosis. Here's another one. This is based on 6,000 patients, a dozen studies, coming into emergency rooms with some acute respiratory complaint that prompts the clinician to thinking, could this be pneumonia? And they get an X-ray. And so our diagnostic standard here is chest X-ray. How good does the bedside exam compare to the finding of the X-ray? Well, you can see there's a whole bunch of findings there that, again, I don't know if the color shows up. There is a white zone there that the findings I don't pay attention to. And so the evidence-based approach looks like this. I mean, the odd patient that you go to the bedside and one side of the chest is not moving, that's a pretty compelling argument that they have pneumonia in that side. But agophony, interestingly, cachexia, your cachectic patients with respiratory distress, much more likely to have pneumonia. Bronchial breath sounds, hypoxemia, and then all vital signs, that is temperature, pulse, and respiratory rate being normal, barely makes it in there as an argument against. Now, what I tell my students is this, that, gee, if you can master this, it would be as if you personally examined all 6,000 patients in these studies and remembered how accurate the bedside exam was compared to the X-ray. So you see, this approach, it's not so much the value of the number, but it just really streamlines what should you focus on when you're making these bedside decisions and diagnoses. Okay, so that's, and there's many, many aspects of the physical exam where this has been worked out. Those are 3 examples. What about this business about stop rules? I think this is key for our learners to learn. What stop rules are combination of findings where the evidence is looked at, these combinations of findings. It makes a diagnosis so unlikely you can stop the workup. It excludes disease. And these, I think, are important, especially in our technologic age where it's so easy to order the CT or the diffusion-weighted MR. If you have something that can give you the confidence that the disease is so unlikely, these are worth teaching. The stop rule I'm going to share with you is in patients who come into the emergency room with acute vertigo, nausea, and vomiting. And most of those folks, that's called the acute vestibulopathy. Most of those folks will have peripheral vestibular disease. But in the elderly who have risk factors for stroke, a few % of them are the beginnings of a medullary stroke or a cerebellar stroke. And so the question here is it possible that my patient with vertigo, nausea, and vomiting is the beginnings of a cerebellar stroke? Okay? There are actually 3 studies that have looked at this. There's been a great interest in this. So these numbers are based on 200 patients, All of these patients are elderly with risk factors for stroke who come in with this acute vestibulopathy. Do they have a stroke or not? And our gold standard here is a diffusion-weighted MR. And so the numbers off to the right, the big positive LRs, are those findings that increase probability of stroke. And then the findings way over to the left, the small numbers, are the findings that make stroke unlikely. This is probably peripheral vestibular disease. There's a lot of numbers here, but do you see way over there off the ruler on the left is something called a Hintz battery being negative. That has a likelihood ratio of 0.02. And as it turns out, in these 200 patients, 30% had the, quote, negative Hintz battery, which I'm going to describe for you in just a moment. And that made the diagnosis of stroke so unlikely, no further testing is required. So what is this negative Hintz battery? Hintz is an acronym. The H in the I is head impulse test. The N is a special kind of nystagmus, which I'll define in a minute. And the TS stands for test of skew deviation. So skew deviation is pretty simple. You just look at the patient's eyes, and they're malaligned. One's a little bit higher than the other. They have an acquired hypertropia. That's called skew deviation. That's a finding of a posterior cerebral stroke. That's not a finding of peripheral vestibular disease. The N stands for nystagmus. It's a bidirectional nystagmus. So everyone with vertigo, if you look one direction, the amplitude of the nystagmus increases. And that's true in peripheral vestibular disease and in central vestibular disease. The difference is when you look in the opposite direction. Someone with peripheral vestibular disease, the nystagmus will disappear. Someone with a cerebellar stroke, you may get what's called a bidirectional nystagmus, where the nystagmus reappears going the opposite direction. That's a sign of a stroke. The head impulse test, that's basically a test to test, is there a peripheral vestibular problem? So when I have my finger right here and I'm moving my head back and forth, you might try that and just move your head back and forth. You can keep that finger just in absolute focus. And the way you're able to do that is you're using your semicircular canals to do that. In fact, hold the finger and move it back and forth. It's blurry. But if you hold the finger still, the head back and forth, perfectly in focus. So your eyes are making exact opposite movements to the head movements using your semicircular canal. So the head impulse is pretty simple. If I have peripheral vestibular disease, when I turn my head, when you rapidly turn it, and I'm the patient, the doctor's right here, he says, look at my nose, and you rapidly turn the head, and you ask him to stay focused on that finger. If I have peripheral vestibular disease affecting the side that I'm turning my head to, the eyes will rotate with the head, and you'll see them come back. And so they're unable to maintain on that target. So a positive head impulse test, you have that corrective saccade, means peripheral vestibular disease. If it's absent, it's a favor of a posterior stroke. Well, anyway, if you have these three findings, positive head impulse test, no bidirectional nystagmus, no skew deviation, so the three findings you'd expect in peripheral vestibular disease, the possibility of stroke is so unlikely you can stop the workup. And I want to compare this to what was the likelihood ratio for a negative diffusion-weighted MR in this study. There were 8 strokes that were missed on the first diffusion-weighted MR that were picked up on day 1 or day 2 of their hospitalization. So this is a slam dunk. You can put the brakes on the workup. And as I said, in this study, 30% of the patients had the negative Hintz battery. So that's a complicated one, but it's, to me, very compelling value of the bedside exam. These stop rules, and here's some others. You're familiar with most of them, I'm sure. The Ottawa ankle rule, don't need to x-ray. The Heckerling score, this is very valuable in the clinic. In my patient with acute respiratory complaints, do I need to get an x-ray and take the time of getting the x-ray and back and waiting for them? If they have a score of 0 or 1, pneumonia becomes so unlikely you can stop. There's an older Goldman classification for the acute coronary syndrome that makes life-threatening complications so unlikely they don't need to be admitted. The Wells score for DVT. And then and those of you who work in ERs probably know the Alvarado score. That's a score of 4 or less, makes appendicitis so unlikely imaging is unnecessary. Now some of these granted combine history and physical. A couple of them also include one lab, but most of this is the bedside findings. And this is an important part of your curriculum, I think, when you're teaching physical exam to your learners. Okay. Curriculum number 3, predicting prognosis. How often have you guys gone to the bedside of two patients who have identical echocardiograms? And their echocardiogram shows dilated ventricle and an ejection fraction of 20%. And you go to the bedside of one patient, patient A, and they have all the classic findings of congestive cardiomyopathy. They've got elevated neck veins, the S3, the displaced apical impulse. You shake their hand, they're ice cold, they have a narrow pulse pressure, they're not perfusing. And then you go to the bedside of patient B, and all of those findings are absent. And this is, I think, a real frontier. This really could be a frontier for physical exam. Those two patients are classified the same the way we categorize disease nowadays based on echo, dilated cardiomyopathy. So what is the value of the physical exam when really what we're interested in is the echo? And this is an opportunity for you to teach how bedside findings predict prognosis. And this has been worked out in pneumonia, it's been worked out in COPD, it's been worked out in pulmonary embolism, and here it's been worked out in heart failure. As it turns out, if you have these classic findings, you're much more likely to die, have short-term mortality. Most of these studies are 1 year, some are 3 months, than if you lack these findings. That's, of course, not a teaching point you want to deliver in front of the patient, but it's an important lesson, for your learners that, yeah, okay, of course we want to know what the echo shows. And yes, we're going to categorize them by their ejection fraction, but nonetheless, these findings still have value because if they're present, it'll help you in triaging patients. Perhaps they respond differently to treatments. As I said, this might be a frontier for future studies in physical exam. Important lesson number 4 is that decisive findings are sometimes absent. And so, you get all these likelihood ratios and you think, I can answer anything now. I've got all these numbers. But as it turns out, and you guys know this already, let me give you this example. You go to the bedside of a patient with a systolic murmur. And this murmur extends from their apex, so you can see over there on the far right, from their apex all the way up above the third rib across the sternum to the first right parasternal space. And I would call this pattern a broad Apical-Base pattern. And so the guy on the right barely meets the definition of this pattern, and the guy on the left meets it and goes beyond, both clavicles, both necks, out to the axilla. So both these have the broad Apical-Base pattern. This pattern, if you hear it, you can be confident, walking away from the bedside, that this is coming from the aortic valve. And in studies of this pattern nowadays, 98% of people have increased velocity coming across that aortic valve. That's what's creating the sound. Now, here's the clinical problem, though. 30% of these folks have just increased velocity and no stenosis. They're anemic, thyrotoxic, pregnant, hemodialysis fistula. Some reason there's just a big jet going across that valve, but no stenosis. And about 3/4 have stenosis. So that's the question at the bedside. You hear this pattern, you make the teaching point, we know this is coming from the aortic valve, but is this aortic stenosis, or is this just increased flow without obstruction? So here's the evidence, and I'm not going to go over everything. What I'd like you guys to focus on is, I highlighted it in blue here, I hope you can see it in the very bottom. Going to the right, the big positive numbers argue for stenosis, and the small numbers off to the left argue for increased flow without obstruction. And I highlighted here on the bottom left in blue a brisk carotid upstroke. So you just go feel the carotid. And if it's brisk upstroke, you can be confident this is not aortic stenosis. This is increased flow without obstruction. The likelihood ratio, I think, is 0.05. And then if you go over to the other side, well, gee, if we have pulsus tardus, a delayed upstroke, you can write home that, gee, this is aortic stenosis. And you would think you can do this in everyone. But here's the problem. Here's what's missing from this slide. And that is, there are 3 findings, actually, with the carotid upstroke. It can be delayed. It can be brisk, the bottom row, or it can be normal. So you lay your hands on the carotid, and you're not convinced it's delayed or brisk. And as it turns out, the likelihood ratio, the far right, for the normal carotid upstroke, unhelpful. It just doesn't help you at the bedside, and that's an important lesson. 61% of people with this pattern, you will feel the carotid, and it won't impress you as either being delayed or brisk. So that's the lesson at the bedside to your learners. If you feel a delayed upstroke, very compelling argument for stenosis. If you feel a brisk upstroke, compelling argument against. If you feel a normal upstroke, unhelpful. That patient still could have aortic stenosis, still may just have increased flow without obstruction. So these decisive findings sometimes are absent. Okay, we're moving a little bit away from evidence-based, but another lesson I really want to make with my learners is that empiric observation has value. And this is my only quiz. What does this patient have in this sort of painful rash in a dermatomal position? The patient has zoster, of course. Now, there's no likelihood ratios here. In fact, there's no diagnostic standard here except what you saw at the bedside. And I make this point, even though my passion, of course, is evidence-based physical exam. Actually, the real reason students need to master physical exam is because a large chunk of diagnosis, there is no diagnostic standard beyond your observations at the bedside. And there are many examples. The entire field of dermatology is that way. How do you know someone has cellulitis? There's no diagnostic test. And there was a study from the UK where one of the hospitals took all the patients with clinical cellulitis, made them see dermatologists first, and fully 30% were thought to have eczema or gout or other things. So the point is, how do you know someone has cellulitis? It's what you look, see, and hear, and feel at the bedside. Erythema multiforme. Most of neurology is that way. We did the Parkinson's disease example, and yes, there's all these fancy imaging, but really, you only make the diagnosis of amyotrophic lateral sclerosis at the bedside, radial nerve palsy at the bedside. Musculoskeletal exam is that way. Patients have rheumatoid arthritis because they have the symmetric polyarthritis. And if their serology is negative, what is it called? It's called seronegative rheumatoid arthritis. So again, the standard was what you saw at the bedside. There's still 2 cardiology diagnoses for which there's still lacking a solid technologic standard, mitral valve prolapse and pericarditis. The recent study in the New England Journal looking at colchicine and pericarditis, if you look at the small print, how many had effusions on echo? It was, 50, 60%. That means 40, 50% didn't have effusions. How did they get diagnosed? They had a rub. They had the characteristic chest pain they had. ECG findings. Okay, ophthalmology, pulmonary, vitamin deficiencies, those are bedside findings. And anyway, we can go on and on. So a very important lesson for your learners is, yeah, likelihood ratios are nice, but there's a whole chunk of what we do at the bedside for which it really do have to master the physical exam. Also, I think bedside findings can be quite decisive. I'm just going to share with you a case that I encountered several months ago where I think, you just went to the bedside and there was a finding that just was a curveball, that it's so absolutely decisive it changed everyone's thinking about the case. So let me just show you this. This is a guy that came into our emergency room with 5 days of progressive pain and swelling in his left posterior neck, followed by fever. And then he couldn't really move his neck very well. And on exam, he looks pretty sick. He has sepsis physiology, he's tachycardic. And then the big finding was his entire left neck and occiput was inflamed. He's got a white count. So just a quiz, if wherever you work, in your emergency room, if a patient comes in like this, what do you think the next diagnostic test is going to be? CT, good, okay, so he gets a CT, and what it shows is a lot of inflammation and swelling in his left neck and occiput. But there's no abscess. There's utility here. And so people were really perplexed. What in the world is going on? He was examined by an ER doctor, the house staff admitting the patient, the ENT fellow, the ENT attending, and, is this necrotizing fasciitis? What's going on? And then at the bedside, I hope that shows up. Can you see what he has, those little gelatinous things on his hairs? And then if you look real carefully, there's movement in his hair, and there you go. And under the microscope, he's got the little head lice. So this is a case of head lice. And, it illustrated to me, this is not Joseph Perloff, diagnosing single ventricle at the bedside, and everyone goes, whoa, this is head lice. But I've sort of kept track in my own career. How often when you go to the bedside where you're responsible for the patient's care, Has there been a finding that has just totally shifted everyone's thoughts? I mean, we've got all the labs, we've got the history, we've got the imaging, and then you go to the bedside and you go, whoa. And at least in my practice, and other people who've published this, it ranges between 1 out of 10 to 1 out of 5, especially if you're on the acute hospital side, where there'll be a finding. And so one other lesson is just, go to the bedside, attentive and willing to be surprised that there's going to be perhaps something there that would totally shift your thoughts. So I think these sort of empiric observations, it's not evidence-based, but it's often very decisive and just as fun as the technology that we use. Okay, my last point, and Abraham and John both have touched on this, but in your bedside rounds, if you can include stories, either from your past experience, the history, whatever, that really will engage your learners. I'm just going to share with you my last Parkinson's disease story, but this is something you might hear. Here we have James Parkinson, and there's his essay on the shaking palsy. It was written almost 200 years ago. And this is the question I'll ask my students. Well, James Parkinson, in 9 pages, described all the findings of Parkinson's disease, except one. And so we've got insidious onset, asymmetric resting tremor, bradykinesia, rigidity, postural instability, sialorrhea, hypophonia, flexed posture, en bloc turning, shuffling steps, festinating gait. The whole thing is there, except one. And the quiz is, which one didn't he describe? Micrographia. That's not your choice. but you may be right. Actually, I think he did include that. Anyway, it was here in the front. It got the correct answer. The correct answer is rigidity. And this is why historians believe that Parkinson never touched a patient, that his entire description was from inspection. So anyway, you can add a little color to your rounds. That's something you can quiz them with. Okay, so teaching at the bedside, I've gone a little bit away from evidence-based, but the first 4, we're dealing with evidence-based likelihood ratios, really do streamline our approach to patients. They improve our accuracy and confidence. Stop rules, a very important part of our curriculum. They're being increasingly developed. If diagnosis is technologic, you already know the X-ray shows Mr. Smith's got a pneumonia. Well, you can still use the bedside to teach Curve 65. These are bedside findings that allow you to predict the prognosis in pneumonia. So move to prognosis. Decisive findings, an important lesson, sometimes aren't there, and the learners need to know that. Empiric observation will often trump technology. Go to the bedside with that expectation. You'll be surprised. It's as decisive and certainly as much fun. And then finally, stories will promote interest and understanding. And that's all I brought. But be happy to entertain any questions. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.